All right. Hello and welcome to Great Plains QIN Friday Focus for Health. My name is Susan Wilcox. I'm a registered nurse and a quality improvement advisor. I'm joined by my colleagues Jennifer Lochner, Stephanie Hansen, and Tammy Wagner. This Friday Focus for Health is hosted by Great Plains Quality Innovation Network, the Centers for Medicare and Medicaid Services Quality Innovation Network, Quality Improvement Organization for North Dakota and South Dakota, and will focus on multi-visit patient and reducing preventable ED visits. Unfortunately, I cannot join you by camera, but if you are able and willing, please do so. Today's webinar is being recorded and will be posted within 1 to 2 business days on our website at greatplainsqin.org under the Friday Focus for Health link. We will also share with you a resource document with all of the resources that we talked about today. Kelsey will put that in our chat feature. We've all heard the term super user, frequent flyer, and those are something that we would like to get away from. That's a negative connotation, and we would like to change how we refer to people that frequent the services of the emergency department. Since the launch of CLASS and Health Equity in 2000 by the Office of Minority Health, the concept of a new, more positive terminology has been introduced. If you're not familiar with CLASS, there will also be a link in the resource document. CLASS is about respect and responsiveness. Respect the whole individual and respond to the individual's health needs and preferences. Providing CLASS is one strategy to help eliminate health inequities. By tailoring services to individuals' culture and language preferences, health professionals can bring about positive outcomes for diverse populations. We must also remember that dignity and quality of care are rights for all and not the privileges of few. The multi-visit patient is defined as a patient that experiences 10 or more emergency room visits within a rolling 12 months. These patients use a disproportionate amount of healthcare resources which can impact readmissions, ED throughput, and length of stay. They often have complex clinical, behavioral, and social needs that require coordinated care across multiple providers and settings. Some healthcare organizations have developed strategies to improve and streamline care for MVPs by creating individualized care plans, connecting them with hospital and community resources, and tracking their progress and outcomes. Dr. Amy Botwell developed the MVP method to improve the care and delivery system that has helped reduce acute care use. Dr. Botwell is the president of Collaborative Healthcare Strategies. She is a nationally recognized leader in the field of reducing readmissions and improving care for the highest risk and multi-visit patients. As the developer of STAR, Aspire, Aspire Plus, and the MVP methods, she has worked with over 275 healthcare teams in 40 states to implement the MVP method. The main principles and actions of the MVP method are as follows. Identify and prioritize MVPs based on their utilization patterns, clinical and social factors, and potential for impact. Engage MVPs in a trusting relationship and assess their needs, preferences, goals, and barriers to care. Develop and document individualized care plans that address the root cause of the frequent utilization and align with the patient's goals. Implement and coordinate the care plan using a multidisciplinary team approach and leverage community resources. Monitor and evaluate the progress and outcomes of the MPPs using data and feedback to measure improvement. There are 3 distinct developments to the MVP method. First is that it uses a threshold approach. Every patient who meets the definition of MVP and is served by the healthcare pathway. This prevents predetermination of impactability. Just as we utilize algorithms to respond to a heart attack patient to deliver consistent response, we also respond to the patients experiencing high utilization with consistent response. Second, the primary objective of the team is to determine the underlying driver of utilization. This is distinct from the chief complaint or the diagnosis and distinct from other health-related social needs. What is the unmet need? Third, the priority focus of the team is to address and mitigate the underlying driver of utilization. Leaders of care delivery transformation are called to action to create the processes, partnerships, and other services needed to respond to the issues. MVP teams build that response system by convening an interdisciplinary team that is charged with creating links to the services and teams that exist in their community. This includes payer-based care management, ACO-based care teams, and community-based services. You can find more information about Dr. Botwell and the MVP method also included in the resource document. I'd like to turn it over to Tammy now so she can discuss the North and South Dakota data.
All right, thank you, Susan. So in the next few slides, just going to show you some reports that we have on our website, and they're just part of the reports that we have related to the ED visits among, we still call them super utilizers in these reports, but we're going to talk about them being MVPs, so multi-visit patients or persons. So when we think about drivers of utilization, we want to know the data. The data we have is in our participating geographic locations. So as you can see here, such as this North Dakota report, we have the Bismarck, Camden, Fargo, Grand Forks, Minot, Western, North Dakota as a whole state, South Dakota as a whole state, and then Great Plains as a region together. So that's North Dakota and South Dakota combined. So the following reports contain data for emergency department utilization for North Dakota and South Dakota and are taken from Medicare claims fee-for-service data, and that's what's used to calculate the measures in these reports. So these are ED visits among MVPs. This is the rate of emergency department visits per 1,000 Medicare fee-for-service beneficiary years among those MVPs or super utilizers. And one beneficiary year is comprised of 12 months of original Medicare enrollment. So for this report, a super utilizer or MVP are those Medicare beneficiaries who've had at least 4 inpatient discharges or at least 5 emergency department visits, observation stays, and inpatient discharges combined in the last 12-month period immediately preceding that performance period. So needed to explain that just a little bit. When looking at multi-visit patients identified in your communities, common characteristics as seen in most communities are that they may be medically complex, they may have some substance abuse, they may have behavioral health challenges, there might be some social isolation. They might have a perception that the emergency department is the only place to go due to a lack of community resources or a perception that they have no community resources, or that the individuals don't feel that they are in control of themselves or their care. So in this report that you're seeing is the ED visits among super utilizers, the trends over time. And this is March of 21 through December of 22. Again, claims data, so it's a little lagging in time. But again, we have this broken down. So this is just a report to have you look at your own organization and how you might be affecting in your area those MVPs. You know, if you look at Fargo area, this could be, you know, a couple different MVPs that are accessing the emergency department in that area many, many times over. So to identify who that or those people are and really trying to find what the reason or the driver is would be important. Now we're going to look at, this is South Dakota report and the different PCHs, so the Partnership for Community Health, so Central, East Central, Northwest, Northeast, Western, and then South Dakota as a whole, North Dakota, and GP Quinn identified in this report. And then similar to the North Dakota, here's South Dakota. And then we can talk about other drivers of utilization. So the inability to navigate the resources that are in the community, those social determinants, food or lack thereof, the lack of money to gain the food, good foods, lack of transportation, medication, unable to afford meds that they need, or the co-pays, lack of insurance, a lack of a primary health physician, a lack of mental health resources, maybe using the emergency department for non-urgent care, the medical issues that they have, lack of same-day sick at primary care, dental issues, chronic medical conditions that aren't managed, and lack of patient engagement. And we need to know the why behind that. And then all the success stories that we've heard in all of the communities. And when I say this, that community is a part of all of these, it's community collaboration, the connection to primary care and ED transitions of care, community health worker programs, community paramedic programs, community resource advocates, and community transformation. Now I'm going to turn it back over to Susan.
Dr. Jeffrey Brenner is the Executive Director of the Camden Coalition of Healthcare Providers. He's another innovator that recognizes the need for reform, and in this video, Dr. Brenner talks about his role in improving care and reducing costs.
Running a primary care office in Camden is like having a focus group every day, tell you all the failures going on all over the delivery system and not having any power to impact that. We're taking really vulnerable sick people and not taking good care of them. And we're spending a lot of money in the process, and we can do better. So I felt like if I reached up out of my office and grabbed a hold of a big data set, that I could begin to prove what I was seeing in my office. We went and got raw billing data from all 3 hospitals in Camden. As we began to map that, graph that, charted it, we realized that these big data sets had a lot of power. We learned that 20% of the patients were 90% of the cost. Someone had actually gone to the emergency room 113 times in 1 year. Someone had gone 324 times in 5 years. We need to figure this out, because if you can fix healthcare for a high utilizer, you really can fix it for everyone. So in my mind, hotspotting at Camden is really about strategic use of resources that respond in real time to problems. Right now, we have a passive medical system that waits for you to come to it. And what we need to do is create a medical system that actively seeks out sick people and takes much better care of them. We managed to win a grant and put together an outreach team to go out and meet the sickest, most complex, high-cost patients in the city, super utilizers, and deliver better care to these patients. I'm deeply motivated to fix the system because I've seen the impact on a day-to-day basis in people's lives. The innovation that we're figuring out here in Camden is going to mean better care for everyone.
Dr. Brenner has an annual budget of about $5 million, 50 employees, and cares for 125 patients. The database that he created identifies hospitalized patients with complicated medical and social needs. A care management team consisting of a social worker, nurse, community health worker, and health coach visit the patient in the hospital. They review prescribed medications, confer with the doctors and nurses, and help with the discharge plan. The team members visit the patient at home immediately after their discharge and provide ongoing support for 2 to 9 months. The services that they provide include connecting the patient to a primary provider, accompanying them to appointments. They help line up and social services that are needed, and the goal is to leave the patient with the ability to manage their health on their own. This model is proven to reduce costs. The first 36 patients averaged a total of 62 hospital and ER visits in the first month before the intervention, compared to 37 visits the month after. Their hospital bill fell from a total monthly average of $1.2 million to just over $500,000. savings that benefit Medicaid spending and hospital charity care costs. Implicit bias is another factor that impacts the care delivered in the ED. Implicit bias, also known as implicit prejudice or implicit attitude, is a negative attitude of which one is not consciously aware against a specific social group. This next video describes how implicit bias affects healthcare.
How do you know if a face is alive? For most of us, this isn't a hard decision. Take a look at this face. Is it alive? Can it feel pain? It should take a fraction of a second to decide. Of course not. That's a Ken doll in his 50s. It's not a real human. It can't feel pain. It doesn't have a mind. So here's the more interesting question. Where is the tipping point? Just how human does this face need to be for us to start thinking, okay, there's a mind in there. This face can feel pain. According to psychologists at Dartmouth, the average answer here is about 67%. Once a face is about 67% human, it looks alive, it looks like it has a mind, and it looks capable of feeling pain. But this threshold isn't set in stone. Research shows that if the face in front of you is somehow not like you, let's say it's a student from a rival school, someone who has different politics, or even someone from a different racial or ethnic group, these faces, the faces of outgroups, now have to be significantly more human than an in-group face before you're willing to say they can think or feel. This isn't a conscious decision. It's an implicit bias in perception, ticking away in the background of our minds. And there's a natural question that follows. If it's harder for us to see some faces as capable of feeling pain, could this make harming them easier? Even when we're looking at people who are undeniably 100% human. It's possible. NFL injury reports have shown that Black football players are deemed okay to play more often than white players with similar injuries. And in healthcare, hundreds of analyses show that Black Americans are less likely to receive pain medication than white Americans reporting the same level of pain. This is true in big cities and small towns, across socioeconomic class, and for many different kinds of pain. It's even true for children suffering from appendicitis.
Essentially what we found was when children were presenting with similar levels of pain, Black children had 80% lower odds of receiving opioid medications compared to white children.
The simple truth is we see some people's pain differently. Psychologist Kelly Hoffman and colleagues found that many of us, including medical personnel, implicitly hold the false idea that Black people feel less pain than white people. From simple paper cuts to slamming a hand in a car door, the same injury was judged to be less painful in her experiments when it happened to this Sam rather than this one. And this is a bias that affects more than just how we see others' pain. It can also impact how we treat it. The medical students and residents who showed the greatest bias when they did this task were not only more likely to endorse false statements, like Black people have thicker skin than white people, they were also more likely to make inaccurate treatment recommendations for Black patients. Now, remember, these experiments aren't studying explicit bias. After all, these are doctors, a population of people who have pledged to do no harm. But no matter who we are, hidden biases in our minds can influence what we see and then how we act. So let's talk about solutions. When it comes to pain management, Professor Mahzarin Banaji has an idea for hospitals: an in-the-moment intervention.
You type a painkiller that you want to prescribe to a patient into your electronic system. Let's say codeine. Your software should return a little graph to you that says, please note, in our hospital system, this is the average amount of painkiller we give to white men. This is the average painkiller we give to Black men for reporting the same level of pain. You're the doctor. You're the expert. Only you can decide what is right for your patient. But it is important to do so with awareness of the pattern of bias in your own healthcare system.
This carves out a moment for double-checking decisions. Sometimes a well-timed reminder is all we need to outsmart our minds.
Recognize how your own experiences may have formed social perceptions and bias toward patients in your care. Early on in my long-term care career, about 15 years ago, I started working at a long-term care facility out in the Black Hills. And one morning I was at report, and one of the med aides popped her head in and said, "You're going to have a heck of a weekend. Georgia and Dwayne are on a roll." So I thought, what can I do? Because inevitably every weekend, one of those two, they were a married couple that lived across the hallway from each other. And one of those two would end up in the ER every single weekend. So I got my stethoscope and my blood pressure cuff, and I went down and I took their vitals and spent 5 minutes with them and kind of forgot about them for the rest of the day. And at lunchtime, the med aide that had popped her head in said, "What did you say to them?" And I said, "Nothing. I just paid 5 minutes of attention to them." And she said, "Well, they haven't been on the call light all morning, and we're having a good weekend." And we never heard about them for the rest of the weekend. So just in that moment, I realized that I kind of had set myself up, at the beginning of my shift, thinking I was going to have a bad weekend. But just that 5 minutes of attention I paid to those people meant the world to them. And we had a great weekend. And from then on, whenever I worked on the weekends, we made sure we did that. And I even got some of the med aides to start doing that with them also. Acknowledge your bias. Everyone experiences bias, as humans or brains are wired to look for patterns and create shortcuts based on our environment. This causes us to develop subconscious neural connections that influence our actions. By exploring our bias and recognizing that we are letting it influence our actions, we can work to change our conditioning. There will be a link to an implicit association test included in the resource guide. This measures attitudes and stereotypes that we subconsciously associate with different concepts like age or race. Challenge your negative bias about specific groups that perpetuate negative stereotypes. Am I treating this person differently because of bias? And reflect on your own assumptions. Be empathetic and ask, how might this person be similar to me? Try to expose yourself to other people that have different perceptions or experiences. Find ways to learn about minority populations that you don't regularly interact with. Gather information through movies or reading books, and try to learn more about different minority groups. See differences. The idea of being colorblind negates or minimizes a person's lived experiences. Be an ally and step up and advocate for people experiencing bias. Help to create positive experience for yourself and them. Recognize that this is stressful and painful, and the reaction to an uncomfortable moment is fight or flight. Try to stay present, take a deep breath, keep educating yourself, and you can counter your stereotypes. Engage in dialogue. Try talking to a trusted friend with a different perspective. Ask them about their experience in the healthcare system. Ask yourself if you have ever contributed to the bias that person may have felt. Finding your own aha moment is critical. The oops and ouch approach can aid in having these conversations. Start the conversation from a mutual assumption of good intention, so that when something offensive or hurtful is said, it is addressed immediately, and with that context, there's no blame or shame involved. Practice this approach, and if someone feels hurt or offended by your comments, say ouch. They say ouch. In response, the person making the comment says oops. This allows you to share your concerns in a way that inspires conversation. And thank you all for joining me this afternoon. I'll turn it back to you, Tammy.
All right. Well, we have some resources. These will all be in the resource document that Kelsey, I'm sure, has shared throughout in the chat. I do want to highlight this episode 161, High Utilizers. It is a podcast with Dr. Amy Boutwell, and she's just interesting to listen to. I would encourage you, if you're working on high utilizers, reducing your emergency department. She's got a lot of great thoughts on how to do that. So that will be in there. Take a listen to that, along with all the other resources, but I did want to highlight that. That's a good listen. All right, we're going to move into our office hours, questions and open discussion. So I don't know if there's any questions in the chat. I know Jennifer, you've been
Not
looking.
seeing anything yet.
Okay, I'm going to move it to the last, just so we get people to complete the evaluation link while we're getting any questions. I do have to start thinking. I have a poll that I'm going to launch. I actually have 3. I'm looking to see what time, and we have a few minutes. The first one I'm going to launch is if people are actually working on reducing emergency department use. So that would be if you're a hospital, if you're a clinic, working on those clinics. I've worked in all areas, but I know sometimes we joke about the clinics. We're in the nursing home, and it's always send to the ER. If you're a clinic, you don't have any open space. I know their clinics are trying more and more to have more open hours for patients to come in. I'd love to hear if that's happening more, longer extended hours, especially for those nursing home. If there's more nurse practitioners going into the nursing homes after hours too, because we know it's not always that 8 to 5 when things happen. Urgent care, we've talked a lot at Great Plains about, that's what urgent cares were for, and we're hearing a lot of urgent cares that are open a couple hours longer than an office. They're closing at 6. So it's still the emergency department that is taking on the brunt of what I thought the urgent cares were going to be taking on, but they're just extended a little bit longer than the emergency or the office clinic hours. All right, do we see, is everybody seeing we are currently reducing emergency department use? So it's yes, no, or not sure.
Do you see the results, Tammy?
I cannot.
Okay, it looks like 88% are saying yes.
Awesome.
Which is great.
That is
1%
great.
says no.
Okay. All right.
So I guess my question would be, is anybody, if they do have a best practice, what is that looking like? And if they'd be willing to share,
Yes. If anybody's willing to come off mute. Little space here. Anybody? Are you working in your community? Who are you working with? What are you working on? Okay. See something in chat if somebody can read that. I just can't.
Don says we are just in the data collection phase, just getting started.
Okay. Perfect.
That's great.
Okay. I'm going to launch this next one, which talks about the data, asking that question. If you're actually looking at, we are reviewing our internal data of multi-visit persons and using this data to drive the improvement. So yes, no, not sure, or going to now. I'll give a few seconds. When you see it slowing down, Stephanie, if you want to share what the results are.
Yeah, it looks like 66% say yes and 16% say no.
Okay.
And then 1% says they are going to now.
Okay. I think I saw somebody flash something in chat.
Yeah, do you want me to go ahead and read that
Yeah,
one too?
yeah,
Okay.
yeah.
Shelley says, our issue here is that the clinic is too booked, so they tell us to send the resident to the ER. In a prior facility, they established an on-call each day that MD, PA, or CNP would come see the resident.
Yeah.
So that's part of maybe that barrier that's happening because they're just so busy in the clinic, so they don't have time to deal with it. And so they're saying, let's just get them to the emergency room when it probably could have been handled more in a clinic or acute care facility or.
Yeah. So it might take some conversations with that clinic or some collaboration with that clinic, maybe. We were just having that conversation. I don't know if they're employed by the hospital, if they're still a freestanding clinic. That's kind of that drive towards being employed with the hospital. That's one of those quality improvement areas that the hospital's looking at with employed physicians, that if they're still freestanding, they don't have that kind of, I don't want to say oversight, but it just isn't as identified. So working with in collaboration with the clinics and the hospitals.
Shelley did add that our hospital, clinic, and nursing home are all connected.
Okay.
Which is, it's discouraging, you just feel like when you all are connected that communication piece could somehow be better established, or more conversation can be had before then they do go to the ED or the hospital versus the clinic.
Yeah, I would
As part
definitely
of
say
that class and the trauma-informed care and comprehensive care plans for long-term care that they're talking about, and that's going to be something that facilities will be cited on. And that resource document is a good thing to look at, but you have to think about what is causing that person to seek medical attention, and part of that will be put into your care plan. You'll drill down into the trauma that they've had or different health issues that they've had, whatever their unmet needs are. That's going to help you with those assessments on admission. Look at those things and determine, if there's different ways to respond to those rather than going to the emergency department.
Yeah. All right, I have one last polling question that's kind of the final. Oh, go ahead.
Tammy,
Yeah.
Jessica did add kind of maybe a best practice. She says we have had a FNP come in from once a week to twice a week, and that has helped. Education to nurses to do what we can in-house has helped as well. We had a PIP and we had a PIP and seeing great improvement.
And who was that? That's great.
That's Jessica Dugcart.
Okay. Yeah. More on that. Maybe we can get Jessica to speak about that on another Friday. We'll reach out to you, Jessica.
Yeah, that's great, Jessica.
Yeah. Okay, I'm gonna launch this quick if you guys can just So our organization has an initiative to reduce ED use. We are using, so collaboration with another organization such as, in your community, I'm working with the hospital, with the clinic. If you are those, you're working with your nursing home, home health, FQHC, hospice, EMS to reduce those MVPs, those multi-visit patients, or you're using some sort of community resources. You have a community health worker program, community paramedic, some sort of community resource. You do follow-up phone calls, follow-up visits after discharge from your nursing home or your hospital, or an SDOH resource. You have them follow up with a food bank or transportation for their follow-up appointments or other. And if you choose other, love for you to put in the chat what that other is. So if you can submit, and that'll be our final, and we'll wrap up then. We'll do 10 seconds and then we'll view results. I know I appreciate you guys. We're a little bit over, but okay. What do we have, Stephanie?
Yeah. It looks like a little bit of a variety. The
Okay.
first one, the collaboration with other organizations, we had 40%. And then the other three, we had 1 or 20% in each of the next three that they have
Good, yeah.
utilized that.
I should have said it's multi, so you could have all. You could choose. I should have said that. But yes, I did multi. All right. Was there any other and any chat with the other?
I don't see anything under other
Okay.
and no further chat on that.
Okay. All right. Well, again, and thank you guys so much for sticking around a little longer. And Jessica, I'm gonna reach out to you and hear more about what you're doing. And we'll talk more. We hope you join us next week for some more on this topic of multi-visit patients or multi-visit persons in the ED.
I would just add too, Tammy, if anybody wants to email or send us any information after this, that they do have a best practice or elaborate more on this last question on, how they're using the community resources like the community health worker or anything, because then we can always bring that back too in our next Friday Focus for Health and elaborate on that. So then we can all learn and grow from each other. So
that's right. And you don't have to speak if you have a best practice. This is about sharing and growing in both North and South Dakota and sharing those best practices we can share for you. So, all right.
Thanks.
Thank you. Bye.
Bye. Have a great weekend.